Thank you so much, Elaine, for that nice introduction. And I'd like to thank the organizers for inviting me to talk to you today about this exciting new modality for prevention and treatment of HIV. Here's my disclosure, and here are the objectives for today's talk. I won't read, but you can see here on the screen. So these are the generally accepted definitions for long-acting formulations of medications. So something that lasts for more than a week, greater or equal to a week, for an oral formulation is considered long-acting. For a parenteral injection, greater than or equal to a month, and then for an implant or device, 6 months. And so there are quite a lot of exciting technologies in development for HIV and other indications looking at long-acting formulations. So there's long-acting depot injections, which we'll be talking about today, but there's also microneedle patches in development, novel oral formulations, pumps, vaginal rings, implants, and so on. So we should be hearing more about this in the upcoming weeks to months, and maybe other options that our patients might enjoy. So why do we want this? You know, you in the audience here, many of you are experienced clinicians. We know that daily oral therapy for HIV treatment works incredibly well. PrEP works well too. Why do we want this alternative? So these are some of the potential advantages of long-acting treatment. Obviously, less frequent dosing, as we just outlined. I think an important one for HIV care in particular is to get away from this pill fatigue. I know many of us hear this from our patients very often. It's just they're absolutely sick of taking pills every day and they'd like to have an alternative. Theoretically, bypassing oral dosing using an injection may improve bioavailability, decrease adverse events, and drug-drug interactions, although some of this is yet to be proven. We don't have clear evidence for all of these things, but these are theoretical advantages. Protection of privacy is important, particularly for, I think, patients with HIV infection. If they're on just an injectable therapy, no coworker or housemate is going to see their pill bottle and wonder what that's for. And relatedly, avoidance of HIV-related stigma. This is both internal and external stigma, which is still a major issue for patients, as most of you already know. And we do have some qualitative data from participants of some of the phase 3 trials that were looking at monthly injections of HIV treatment, that not having to take a pill every day and not having to be reminded about having HIV was a huge relief to many patients. So the one unanswered question I would posit is this treatment modality going to improve adherence? And I think we would all love to think that yes, it will, and we all worry about patients in our clinics with who struggle with suboptimal adherence, and maybe this is an option for them. But I will go through the data that we have, and then you guys can decide for yourselves. So do our patients actually want this? So several years ago, I did this study with Charlie Flexner from Hopkins, where we looked at patients in both of our clinics. This is patients with HIV taking daily antiviral therapy, doing very well on it, to see if they might be interested in getting their treatment by injection instead. And you can see the demographics on the left, and then on the right here, looking at the timing of injections for monthly injections, very high levels of interest. And I was surprised by this because I thought that our patients were doing perfectly well on their daily oral therapy, but many of them said no, they would much rather look at something different. So we have now in the pipeline very many potential long-acting formulations. Not all of them are going to make it, but in pretty much every drug class, including some investigational one, there are long-acting formulations of antiretroviral drugs, either for oral formulations, injections, implants, intravenous infusions, and these are the developmental stages that they're in for either treatment or prevention indications. But today we're going to focus on these two drugs, which, as you know, were recently approved by the US FDA for use in patients in combination. So this is the first two-drug, all-injection approved formulations that we have. So I would also remind everyone that Dr. Raj Gandhi will be talking later in this session about other investigational drugs, some of which are on this list. So just to remind everyone, these are the seminal studies for long-acting injectable cabotegravir and rilpivirine. There's 2 phase 3 trials. One's called Atlas, one's called FLAIR. They have a similar design. Atlas was for patients that were on daily oral therapy, doing well, had undetectable virus. They did not have a history of resistance or hepatitis B, and they were randomized to continue their daily oral therapy or to start getting treatment with monthly injections following a 1-month oral lead-in with oral cabotegravir and rilpivirine, just to ensure tolerability. And after the primary endpoint at week 48, many of them have continued in the so-called Atlas 2M study, which I'll talk about in a few minutes. The sister study, FLAIR, was for patients who were treatment naive. They took oral therapy as indicated for 20 weeks, and assuming they attained undetectable viremia, were randomized in a similar fashion to monthly injections. This is the primary endpoint for the Atlas study. This is for patients that were switched from their oral therapy, and you can see in the green bar there, the virologic success rate for the injection arm was very high and basically very similar to the success rate in the purple bar for the continuing oral therapy, and this was well within the 6% non-inferiority margin that was used in the trial design. In the FLAIR study, this is for patients who were started on oral therapy or initially treatment naive and then randomized to actually continue that or go on the injections. Similarly, very high levels of virologic success in both arms and also within the non-inferiority margin for this study too. So this is a little deeper dive into the few patients who did have confirmed virologic failure, some of whom also developed resistance-associated mutations. So there were 3 participants in each of these phase 3 trials that developed virologic failure with resistance, and this outlines them all here. 5 of them were from sites in Russia. They were all thought to initially have A1 subtype virus, but this has since been revised on a further virologic investigations by the team, and in fact, they have A6 virus, which is slightly different. It's also strongly associated with the L74 polymorphism at baseline. So you can see the baseline mutations, which were evaluated using the archive DNA sequencing assay. These are the viral loads in the next column, suspected and confirmed virologic failure. And then you can see the treatment emergent resistance-associated mutations that did occur both to NNRTI and to integrase inhibitors, and the fold change in susceptibility in the final column. So it would be very nice to be able to just explain this away, saying, well, these participants missed their injections and their concentrations got too low, and that's why they had virologic failure with resistance. But it's actually not that simple. So even though for these particular patients, most of them had concentrations that were below the mean for the whole study population, they were well within the range, and there were also participants with lower concentrations that maintained virologic suppression. So it's not quite as simple as that. But as I mentioned, the team has gone on to do a more in-depth evaluation of patients with confirmed virologic failure. And this was presented at CROI and has also been just recently published in AIDS. So this is a univariate analysis of patients with virologic failure in all of the phase 3 trials, and this includes the follow-on Atlas 2M study. So this is 1,039 participants altogether, of whom 13 had confirmed virologic failure. So obviously this is a rare event, but these are some of the factors that played into it. And so the red bars show whether or not a covariant was present, and the blue bars show that it was present, it wasn't present, and then along the x-axis you can see the proportion of patients with failure. So these are the concentrations of cabotegravir and then rilpivirine, BMI of greater or less than 30, the subtype, whether or not they had this A6 subtype, whether or not they had this baseline polymorphism at L74, other proviral resistance-associated mutations at baseline, and female sex, and then whether or not they were on every 8 weeks, which was an option for the Atlas 2M study, or every 4-week injections. And so the multivariate analysis identified these factors which were associated with increased risk of failure. Presence of proviral rilpivirine mutations at baseline, this HIV subtype A6, and or BMI of greater than or equal to 30. So this raises a question of, do we need to start subtyping patients before they go on injection therapy? I think based on these data, I would say, no, we don't, because this is very uncommon. Similarly, we don't need to do archive genotyping. We may need to give some thought about using this treatment modality in patients with higher BMI, although there is an option for using longer needles for such patients to ensure that the injections actually end up in the muscle where you want it to be. Briefly on the safety data for the phase 3 trials, really not all that exciting. You've seen this before. Nothing much happened in either study, which was great. These are the combined safety data in terms of serious drug-related adverse events. But I show this because I know there's interest in weight gain, particularly with integrase-based regimens. And so these are at the bottom, the data on weight increase week 48 from baseline, and as you can see, modest in both arms. So not much happened in terms of weight gain for patients in the phase 3 trials. So injection site reactions are definitely a thing. These were common. Patients in the phase 3 trials did often get injection site reactions. They were pretty much all mild and self-limiting within a day or two. I personally was quite surprised how well these were tolerated by participants at our site. They were a little bit sore for a day or so, but honestly, people didn't worry about it too much, and it did seem to decrease over time. But this is going to be an issue that patients will need to think about and may require some management as this treatment modality is rolled out. So as I'm sure you all know, these phase 3 trial data led to approval by the US FDA of this first complete long-acting injectable regimen, and you can see the indication there on the right. It's basically a switch indication. Adults who are on an oral therapy doing well with virologic suppression and no history of treatment failure. Also note that these drugs are not active against hepatitis B, so those are patients that also will either need to not use this treatment or have oral therapy for their hepatitis B. So at CROI, we learned about the week 96 data for Atlas 2M. So this was the follow-on study to Atlas, which included many Atlas participants and then others, in which they were randomized to continue monthly injections or to go on every 8-week injections. And this was the primary comparison. And so we now have the week 96 virologic data, which showed that there was basically no difference between the every 8-week and every 4-week regimens in terms of virologic suppression. This fell within the non-inferiority margin. And we also got a little bit of information about the small numbers of patients who did have confirmed virologic failure in Atlas 2M, including one who developed this between weeks 48 and 96. And you can see in the two arms, The number of virologic failures was small, perhaps more in the every 8-week arm, and you can see the resistance-associated mutations that were observed at failure for both rilpivirine and integrase in the study participants. So, switching gears now to talk a little bit about long-acting therapy for prevention. And I think many of you are probably very familiar with the results of these two outstanding studies, HPTN 083 and 084, one for cisgender men and transgender women and the other for cisgender women, both with similar designs using a double-blind design, both large studies designed to compare every 8-week oral cabotegravir in the long-acting formulation as compared to standard oral PrEP using tenofovir FTC. Both studies stopped by the DSMB early because of these very spectacular results. This is for 083. You can see the orange line is the incident HIV infection in the injectable cabotegravir arm over time, and the dotted blue lines for the oral tenofovir FTC. So this amounted to almost a 70% reduction in HIV incidence and is clear demonstration of the benefits of the long-acting formulation as compared to standard one pill once a day, which, as you may remember from the original PrEP studies, decreased HIV incidence by something like 40%. For the study in women, even more dramatic results showing almost 90% reduction in HIV incidence, which we were all, I think, extremely pleased to see, in particular because many of prevention studies in women have had disappointing results, and I think we were all excited to see potential option that patients actually seem to like and that worked so incredibly well. So at CROI, we had the closer look at infections in the 083 study in the cabotegravir arm from some post hoc lab testing. And I think I'll just summarize this as saying it was complicated. I would direct you, if you can, to actually follow the presentation. But this is kind of the take-home message. There were 12 incident and 4 baseline infections in the cabotegravir arm. So this is an uncommon event and seemed to happen at different times. So on this slide, the little green things that look like asterisks or little viruses are the timing of the infections, the first 4 at baseline and then the following incident infections that seem to occur at different times during study follow-up, some of them in patients who had stopped getting their injections for whatever reason, and so were theoretically in this so-called pharmacokinetic tail period that we worry about. So pharmacokinetic tail is the amount of time a drug will persist in the body following the last dose, and because cabotegravir the injection is such a long-acting formulation, this persists for months after the last injection, and so we worry that as patients have decreasing exposure to the drug, they may be at risk for getting infections during this tail period. So the take-home message for this is obviously that the cabotegravir intervention was highly effective. Incident infection was rare, as you can see there. But several things were learned. So one of them is that use of the long-acting injections can delay antibody expression. And so it actually delayed detection of infection, including some prevalent infections. So patients actually got started on the injections even though they had HIV infection at baseline. So that is a consideration moving forward if and when this study gets approved and goes into widespread use. Our conventional testing algorithms may not pick up every infection either at baseline or incident infections. There were a small number of failures despite the fact that patients got their injections on time and had adequate cabotegravir exposure, and a smaller number of them, 5 out of 16, developed integrase-resistant mutations with virologic failure. There were 4 infections that occurred during the so-called pharmacokinetic tail, and none of those actually developed resistance, although this number is small. That is still reassuring. And so I think these data do raise the question of, should we be using a viral load test rather than our traditional antibody testing to monitor patients on PrEP with long-acting cabotegravir? Is still an unanswered question, but one that we'll need to consider and may complicate things, although virologic testing is getting more in widespread use and hopefully less expensive and easier to implement. So where do we go now? What is the future for this long-acting formulation? So one of the issues that has come up is this so-called oral lead-in. So I mentioned in the phase 3 trials, patients took oral formulations of these drugs for 4 weeks and nothing really happened. There was really no adverse events, nothing exciting happened. And so in the extension to the FLAIR study, this oral lead-in was made optional. So this is not a randomized comparison. Patients and providers were able to decide if they wanted to take the oral lead-in or not. But as you can see, conveniently, about 100 in each arm decided one way or the other, and the virologic suppression rates were pretty much exactly the same in both arms. So it seems as if this oral lead-in may not be necessary. In the open label PrEP studies that are going on, this is going to be made optional, and I think that's a consideration that we should all think about somewhat as we start rolling out this option for treatment in patients, particularly those that have terrible trouble taking tablets or taking pills. I think we all have a few patients like that in our practice, and the monthly injections might be a great thing for them, but they would have trouble with the monthly oral lead-in, so that would be an option to think about, maybe not even using that. The company are working on using some of the new technologies we talked about at the beginning, such as microarray patches. There is a more concentrated version of the long-acting formulation under investigation, double strength. The injections currently are quite large. Each drug, cabotegravir and rilpivirine, is 2 mils each. So patients have to have sort of 1 in each gluteus medius muscle, and a 2 mil injection is beyond the reach of, self-administration. And so this opens the door to maybe that would be an option in the future. And there's also some biodegradable implants that are non-biodegradable implants that are in development. So what about long-acting antiretroviral therapy in special populations? So pregnant women, as is sadly so typical, were excluded from all of the studies so far, and if they became pregnant on study, taken off, and that is changing now, and so they'll be continued on the cabotegravir rilpivirine long-acting if they want to, after giving consent for this, and with additional PK monitoring, so we can learn about how these formulations function in pregnant women. This will be true for the prevention indication also. There are studies either ongoing or in development for a treatment indication of long-acting cabotegravir rilpivirine in children. You can see them here for older children going on now and younger children in development, and adolescent sub-studies for the PrEP indications are ongoing. So we will have more information about use in special populations. Still not quite for non-adherent populations, but many of us, I think, as clinicians are struggling with how are we going to implement this in our already busy HIV clinic. There's a lot of factors to consider, both at the individual, the clinic, and the logistical settings. Patients are going to need a lot of information about this, just implementing the whole staffing of it. As you know, we see patients now maybe every 6 months, and so having them coming every a month will be difficult. having a coordinator to monitor to make sure that they actually do come will be another challenge, because most of us don't have coordinators sitting around, waiting for something like that to be asked to do. The sponsors are conducting 2 implementation studies as outlined on this slide that are both ongoing, but when completed will inform some of these questions. And so in summary, I think this is overall a very exciting development. I think having more choices for patients and for providers is always good, and I'm excited to be able to offer this to patients in my clinic particularly. I think it's important to note that all of the treatment trials so far have included only patients with optimal adherence. So whether or not this option is going to help our patients with adherence challenges is an unanswered question, but hopefully will be answered by this ongoing ACTG study called Latitude. So if you have the opportunity to refer patients to this study, please do so. We're going to have to adapt a little bit to some different paradigms for patients at risk for virologic failure. I think we're all used to patients with oral therapy, ones that we know are just not refilling their pills. They tell you they're missing, you know that you need to worry about them. But with the injections, it's slightly different, because there will be some that get their injections exactly on time as they're supposed to and may still fail and occasionally will develop resistance. So this is something that will have to be accounted for. And this is, I think, will weigh into the decisions that patients and providers will jointly make about whether this option is suitable for them. And then, as I mentioned, our clinics are going to need to have some fairly serious adjustment to the workflow to address the logistics for this. And just remember, even though there are issues to consider, this is first in class. So many of us remember when this drug came along, Swindells, the first protease inhibitor, and how excited we were about that and how far we've come since that was developed. And so with that, I'll turn this back over to Dr. Abrams for the Q&A session.
Fantastic. Well, thanks for that exciting talk. And even though I heard many of those presentations at CROI, I still learned a lot from your summary. So thanks so much. We have a couple of questions that have come through. I think the first is a question on how long after the CAB injection are we telling patients they're protected when it's used for prevention?
So the implication is that if it's stopped for some reason, how long does the protection persist? Is that your understanding, Elaine?
I think you're saying from if you get a shot today.
Oh, I see.
Tomorrow, do we need to cover them for some period of time before we think the injection provides full protection?
Yes, that's a great question. And so that is one of the issues with the treatment and prevention indications, is that part of the sort of long-acting formulation is it just take a minute to get up to the kind of therapeutic levels that you want to either protect against HIV or to suppress HIV, which is one of the issues of not using the oral lead-in, although that does seem to be a safe approach. So for prevention, it doesn't work immediately. There's some talk about maybe you could include a double dose of the oral formulation, just at the beginning to provide a little bit of extra protection until the levels get to where you need them. And then if for any reason the injections are stopped, people decide they want to go off PrEP, they will be protected for a while, but then you do get into this worrisome area of the pharmacokinetic tail where they may be at risk for an incident infection, potentially with resistance, but we haven't seen that yet.
Super. So I think that there's another question about the tail, and for people who were getting stop cab, how do we have to cover them to provide protection during the tail?
Yeah. So this is, we all worry about this. Obviously, for the treatment indication, it shouldn't really be an issue because the idea is people go on treatment and, stay on treatment forever. And so for whatever reason, they stop the injections. They decide they don't like them anymore. They're sick of the injection site reactions. Then you just, switch them to oral therapy and they're good to go. And so the studies recommended just starting that immediately, even though they'll still have some of the long-acting drugs in their system. You just start them on full dose oral therapy for treatment. For the prevention indication, that is again more tricky, and so if people go off it because they don't feel they're at risk and they're really not at risk, they should be okay. But the drugs can persist for months and months, and so it is a worry. And so ideally, what's recommended is that patients go on oral preventive therapy for a year after discontinuing the injections.
Okay. There's another question of whether there's a concern with cabotegravir, as there were concerns with dolutegravir during early pregnancy and conception.
Yeah. So that's excellent question. They're chemically, similar. We have really pretty much, there were very few incident pregnancies in the treatment trials and some in the prevention trials. There's been no signal of anything to date, but that's an unanswered question that we'll need to keep monitoring going forwards. And obviously, particularly for the treatment indication, we would encourage providers to upload all their information to the antiviral pregnancy registry so we can learn this.
I would add that there are concern around the relationship between neural tube defects and dolutegravir has lessened over time as we've gotten more data.
Yeah.
So we're also being asked whether patients might be able to self-administer.
Yes. So this is a great question. A lot of interest in that. Patients would love to do it. As I mentioned, the loading dose is 3 mils, 2 injections of 3 mils each into large gluteus muscle. And so, pretty much it's slightly difficult to administer. You have to do that Z tracking thing. And so self-administration or even, having a friend or your mother do it, would be difficult. But I think with the more concentrated versions, if we can get the injection volume down, that would definitely be an option for potential self-administration, maybe into a deltoid or something. So it's something that the companies are interested in actively working on. So not for right now, but perhaps for in the future.
So someone else is asking, despite being infrequent, if a patient does develop INSTI resistance while on long-acting, what are their treatment options? Or should PrEP fail?
Yeah. This is also an excellent question. And as you may recall, for the phase 3 treatment trials, patients weren't enrolled if they had history of resistance to other drug classes. And so that would be a consideration for, if you're going to start someone on these injections and they've had a history of, multiple episodes of virologic failure with resistance. I think it would give you pause. But if you have a patient who's essentially had no resistance before, they fail injection therapy with resistance, this isn't being mandated by any of the protocols, but what has happened in most instances is providers have opted for a PI, protease inhibitor-based regimen, which I think we're all more comfortable with, even though it does seem that cabotegravir has a different resistance barrier from dolutegravir and bictegravir, and it may be safe to use another integrase. I think we all worry about that a little bit if there are incident integrase mutations, and so most people have felt safer using a PI-based regimen in almost every instance. So that would be I think, the plan B.
Okay. Well, there are many other questions, but unfortunately we're out of time. Thank you so much for the great talk and for being in the hot seat of answering all these questions. I think we now will turn to our next speaker.